for clinical practice, but for many other stakeholders who are in many ways impacted by the need to deal with obesity. My role here is in this commission is as a coordinator chair of the commission, but I also, of course, work at King's College London as a professor of metabolic and bariatric surgery, and I'm also a consultant surgeon at King's College Hospital. So the title of this presentation is practical, maybe a little bit provocative. And as you can see, we ask if obesity is a disease, and if it really is, how do we diagnose it? Is it okay to diagnose obesity the way we normally do, and then call it a disease? And what would be the implication if we did so, etc. So the first thing I would like to say is that when we look at what is the job description of a healthcare professional, and we should probably go back to what Hippocrates recommended. And he said we should cure sometimes, because obviously cure back then and also today are not always available for everything. We should treat as often as we can. But one thing we should always do, which is comforting people who have illnesses and suffer from diseases. Now, I would say that it's safe and entirely safe to state that we don't do any of this when it comes to obesity. We don't cure obesity. We don't have treatments that cure obesity. Even the most effective ones, like surgery, don't always achieve what we could consider a cure of the disease, of the problem. We don't treat it as often as we should, because in fact, even when available, evidence-based treatments are not delivered to people who need it. And certainly, we don't comfort people with obesity. If anything, we actually have a very strong, widespread bias in society, and we stigmatize, stereotype about people with obesity, and quite often, unfortunately, we even discriminate against people who have excess weight. So how could we get all this so wrong that we do everything opposite to what we are supposed instead to do if we think we are approaching obesity, at least from a healthcare professional point of view? Now, let me see if I can advance. One of the, perhaps the reason, or maybe the fundamental reason for this, is that we normally understand and conceive a difference between a normal state, a pre-disease state, disease state, and complications of that disease in a way that allows us to conceptualize and deliver and deploy interventions as appropriate for that particular state. So you would not think about using prevention strategies to treat a disease that has already happened, because the disease is already past the point of prevention by definition, and so on and so forth. So this classification, this conceptualization is so fundamental for everything we do. But when it comes to obesity, we actually lack that common conceptual assessment of the problem. Now, at least we lack a piece in that continuum, exactly the definition of obesity as a disease. We consider it as a condition. It's not clear if it's a pre-disease or a condition or whatever it is. And then we have complications. We recognize that there are complications of obesity down the road. But the lack of this piece, what I call the missing piece, is so crucial that causes a lot of distortions. For one, the current strategy to control obesity is completely, in my opinion, misled by that missing piece, because in fact we see very often prevention interventions that are good for prevention of obesity being deployed to treat people who already developed the problem, and very severe obesity or very severe problems, health problems, where we already know that prevention is no longer effective. And we reserve treatment whenever we deliver it to the far end of the spectrum, where complications, maybe even end-stage complications, have already happened, of course diminishing the effectiveness of treatment altogether. So this is a major problem, the fact that, and it stems from the very reason that we haven't conceptualized obesity as a disease. The fact that we haven't consider obesity as a disease also facilitate or even encourage what I call quackery, because it would not be tolerable or even possible to have so many science-free advice being given to people with obesity from all sort of people who think they know what it is. They know what everybody knows. This is more or less like football. Like everybody thinks they know football best and better, even than professional coaches, etc. So they know who should play, who should not play, etc. With obesity not being a disease is a problem that it's beyond the control of the medical profession. And this is not because medical professionals still have control of everything, but if something is a medical problem, it is the best interest of the public that this is dealt with competence and experience and expertise and health and by healthcare professionals. But it's not always like that because of that problem. So it would be important to understand if obesity is a disease, but is it? And what is the reality here? Now, there are some organizations that have already recognized obesity as a disease state. The WHO did this initially. I didn't know until recently, but it goes back to 1948. They said obesity should be recognized as a disease. More recently, in the 90s, they have re-articulated this concept even more. But it wasn't until 2013, I believe, that the American Medical Association has reignited a debate around this by voting in one of their general sessions on whether or not obesity is a disease. And by a vote, raising a hand or whatever it was, the mechanism, they define obesity as this disease. The World Obesity Federation has since followed, and other organizations, and interestingly, even some political bodies have endorsed this concept of obesity disease, notably the European Commission, the Italian Parliament, and I'm sure there may be other national parliaments that I'm not aware of. So there are some organizations that really recognize obesity as a disease, at least in principle, even though there is no exact action on or consequence yet on this definition of disease. Now, is it obesity a disease? As there are some organizations that support or endorse that, there are many others and also individuals that actually believe exactly the contrary. And so, unfortunately, this debate has become a really one of the most polarizing debates in modern medicine, where there is a very emotional approaches to the question by some, by all, in a way, either in either direction, yes or no. And you really sometimes see arguments that might be overly emotional or less based on science and facts, but more on opinions. And when it becomes a matter of opinion, it becomes also less easy to disentangle the problems and issues, because you don't base the decisions on facts, but more on positions, and it becomes increasingly difficult to tackle the problem or answer the question. Now, those who think obesity is a disease, they cite the fact that obesity has a distinct pathophysiology. So there is a pathophysiology, means that the physiology of tissues and organs is no longer normal. And that's why a body is able to build up excess adiposity. It's not just that people put it on and off as they wish, but there is distinct pathophysiology. There are biological mechanisms that regulate that. In many patients, but perhaps not in all, there are clinical characteristics of a typical chronic illness. So they say, why should obesity be different than others, and therefore should be recognized as a disease? It also is a situation very often that progress or is chronic and persistent, and has signs and symptoms like many other conditions, medical illnesses. And it does, of course, increase risk of secondary complications as a disease would do. And those who say, no, it's not a disease, though we don't believe so, they say, well, I buy into this. Obesity is serious. It is a risk factor for a host of other diseases and conditions, but a risk factor is not really a disease. People with obesity also, very many of them, do look like healthy by all common standards by which measures of health that we at least think of. And not everyone with obesity has evidence of organ disease or functional limitations here and now, maybe in the future. But with the future, it's the future. So you will make a diagnosis of disease when that happens, not prior to it. And they also say that defining obesity as a disease would unnecessarily medicalize a problem. Given the prevalence of obesity, it could be an intractable problem because the sheer cost of addressing it as a disease with this prevalence, it's just unaffordable and not even thinkable. It's not even thinkable to afford. Now, in practical terms, let me give you two examples that seem to be providing good ammunitions to both camps, right? Like one is this ideal person, Maria. We call her Maria. She's 41-year-old, has a BMI of 34. So technically, she has what we call obesity by BMI standards. However, she has no history of type 2 diabetes, hypertension, and any other metabolic complication. She has no particular signs or symptoms, no complaints. She feels good. She feels in herself. She had a recent routine occupational health assessment where most her vital, all her vital signs were found to be normal. There were only a little bit of steatosis in the liver, but normal function of the liver. No other organ systems were affected. She has a job, actually a physically active form of employment. She's a police officer, and she also is very physically active and socially active. She runs half marathons. She's mother to 3 healthy boys. She's volunteers at charity. So she has a full rounded, healthy, apparently healthy life. And if we were to say that obesity is a disease with a blanket definition across the board, she would need a criteria for disease just based on BMI. But does she have a disease? And this is what some of the people who don't believe obesity is a disease point to, because they say, well, if we make obesity a disease, we will take a lot of people who have otherwise apparently healthy lives, running healthy lives and look healthy, and make them the subject of interventions that might be unnecessary and costly, but also imagine the emotional impact of communicating the bad news to somebody, telling them you have a chronic progressive disease. Is it fair to this person to give that kind of worry to them when there isn't evidence of that happening at the moment? So, of course, this is a concern at an individual level, but it's also a concern at more, at a broader level, more global level. There are recent estimates just revealed last week on the Obesity Day show that by 2035, half of the population of the world would have either overweight or obesity, and 1.6 or more billion people would have full obesity, full-blown obesity of the way we classify it today. So if we were to say obesity is a disease and half of the population might be having it or being borderline to it, I think everybody would say, well, this is just an intractable problem. And the policymaker wouldn't, or a politician would not even want to know, and because there is no way to approach it. So it's it's very important to understand if it is true or not, and or when is it true that obesity is a disease. On the other hand, if you take another ideal example like Jack, in this case, he has actual complaints. He has a BMI in the same range, more or less, of Maria, that you just saw. However, he complains of fatigue. He has dyspnea on exertion. He has recurrent bilateral knee pain with reduced mobility, so cannot even physically exercise to mitigate the problem. Although he's blamed, obviously, for not doing it, but he has no chances to do it. He has had a medical assessment and has actual evidence of alteration in the structure or function of the heart or musculoskeletal system. He has NASH in the liver. He has actually, at the moment, is unemployed as a result of his obesity. and is not able to run any reasonable level of physical activity, including playing with his 7-year-old healthy son, and that makes, of course, him increasingly feeling depressed because of that, and all the other implications. And I think in this case, one could say, well, how different this would be from any other form of chronic illness, and why is Jack not given all the care or the access to the care that other people for other illnesses of similar or even less impact on life would have. So it would be unfair that this person is not properly diagnosed with an illness. So answering this question is fundamentally important, because defining whether obesity is a disease or when obesity is a disease has very many ramifications on public health, for public health, clinical practice, and society. However, answering the question is not easy, and it's not easy for a certain number of reasons, and I believe it's particularly not easy because of some specific issues that are called stumbling blocks that prevent us from answering the question. So what are those stumbling blocks? Well, for one, is this the very approach to this question has been so far quite one of black and white. Obesity is a disease or not a disease. I don't think that's probably the right way of framing the question, because if you do frame the question this way, we are basically speaking of a completely implausible scenario where obesity is either always a disease or not always a disease. And so, of course, both camps I mentioned before will have good arguments against or for this motion. So it's probably the framing of the question has already set us up for failure to respond, to address the question. The other issue is that we have forgotten, we as obesity specialists, obesity experts, whatever, we've probably forgotten what really means to define disease. Now, disease is now very clearly defined, but most commonly, in most situations, in most organizations, in most dictionaries, disease is referred to as a harmful deviation from normal, from the normal structure or functional state of an organism, which is associated with signs and symptoms. So this is what disease should be. And chronic disease specifically, according to the CDC, are conditions that last at least 1 year, require ongoing medical attention, or limit the activities of daily living, or both. So there must be some element of evidence here that there is an ongoing illness or ill health. It's not just a risk factor, but ill health. Now, if you put this together, then you can see that for this criteria are used normally to define and diagnose diseases in other areas of medicine. In fact, if you look at rheumatology, neurology, mental health, doctors and other healthcare professionals, they use clinically relevant criteria, signs and symptoms, etc., to define ongoing illness, whether or not there is an ongoing illness, not necessarily if there is a risk of future illness. Instead, in the current definition of obesity, we have that abnormal or excessive fat accumulation is a condition that presents a risk to health. Now, fair enough, a risk to health is an important thing, but a risk to health is not coherent with this definition of disease that is commonly used in other fields of medicine, where you need signs, symptoms, limitations of daily activities to actually see that there is illness, ongoing illness here and there. So risk to health doesn't mean ongoing disease. It means possible future disease or complication, but risk is by definition something that has not yet materialized. And that's where some people find it hard to bind to the notion of obesity as a disease, because they say, well, it's a risk, but we haven't seen any definition of illness. How does the illness of obesity looks like? Normally we quote diabetes, et cetera, and so and also the risk is associated with an idea of implicitly an idea of future problems, not present, whereas disease is inherently linked to a present issue. Why disease and risk are different? because disease is not usually defined as risk of future illness, with few exceptions where you have genetic conditions with 100% prevalence, penetrance for the illness to happen, and then you can anticipate a diagnosis early on. But there are even in genetic conditions where there is a risk of disease. You don't diagnose disease until the disease has happened. In infectious disease, for instance, you distinguish between contagion and infection and illness. For instance, people can have a positivity to HIV, but they don't have AIDS until they have AIDS, until they have the clinical manifestations and consequence of HIV infection. So we define risk and disease differently. You can have many other situations and examples. So for instance, having a fair skin has been shown to be a risk factor for skin cancer. You don't have skin cancer until you do. You don't think that having a fair skin is a disease just because it elevates the risk of another problem. And the same can be applied to other examples. So for instance, there's a increasing gamma globulins in your blood, could be consistent with a MGUS, which is a condition of risk for developing myeloma, multiple myeloma, but it's not a multiple myeloma. So yes, there is a risk, but it's not myeloma until it is myeloma, and then you diagnose it when the disease happens, and particularly when that condition is actually affecting various sites and organs of the body, particularly the musculoskeletal and the bones, etc. So we don't always differentiate between condition and disease. There's also another problem, in another stumbling block, is the BMI issue. If we were to frame obesity as a disease based on BMI, we would capture a lot of athletes, football stars, boxers, and many other even non-professional athletes, where their body composition is actually healthy, yet they don't have excess adiposity, yet their weight puts them in the BMI bracket of having obesity. And so this is a problem, because we would overdiagnose a disease or illness if we were to use current anthropometric measures of obesity. So there is these problems I've just mentioned have practical ramifications, and I can show how it creates a barrier in communication. Even organizations that recently have made an effort to communicate that obesity is as a disease have changed definition, have used the definition. What they typically say is that obesity is characterized by a condition of excess adiposity that presents risk to health. So according to the WHO definitions. So when they actually try to demonstrate that it's also a disease, they maintain that narrative. They say obesity is a chronic disease, but then in the same sentence, because it presents a risk to health, implicitly contradicting the very statement that they're trying to make, or at least, at the very least, not explaining why obesity is a chronic disease, because that risk to health does not explain disease. And so, not surprisingly, these statements that we have seen coming out from organizations have not really succeeded in convincing anybody. And in fact, they're puzzling in a way, even for healthcare professionals, because you have to say, is it a risk or is it disease? And it's not coming clear from these definitions. So what is a disease? Normally, to make everybody agree on the disease, one should have evidence that there is a clear, distinct pathophysiology or pathogenesis, or the physiology is not normal. There is obviously risk for other diseases and mortality, but that is something that could be common to disease and also to conditions that are not diseases yet. What is really important is to have some other additional characteristic, which is the clinical manifestation, the evidence that there is a clinical illness associated with that pathophysiology, with that alteration of physiology. And now, again, if I say before that we're missing a piece in obesity, we're missing specifically this piece. We have never defined, historically, we have never defined obesity as a medical field, with medical profession. We have never defined obesity as from a clinical standpoint. We have no definition, a clinical definition of obesity. We have an epidemiological definition of obesity, and again, a risk, a condition definition, but we haven't characterized obesity clinically. And that's the missing piece that is, in my opinion, the source of all our troubles, and the number one stumbling block for us to address that disease. that question. Sorry. So just last week we published in the Lancet Diabetes Endocrinology the announcement of the commission, the Lancet Commission on Clinical Obesity, and we specifically say that recognizing a disease without knowing whether and how it causes illness, independent on other comorbidities. So in other words, without knowing what the disease looks like, is really almost a futile task, because there's no way for you to really conceptualize disease without a definition of illness and understanding exactly how illness looks like. So to do just that, to define that, we put together this Lancet Commission on Clinical Obesity, which is a partnership initiative between the Lancet Diabetes and Endocrinology Journal and King's Health Partners and other Lancet journals that will also support in this. The commission is has a steering committee. I'm the chair of the committee, but I'm helped by many other colleagues who are leading, and I'm humbled by the level of expertise and authorities of other colleagues who are sitting in this commission, both in the steering committee. As you can see, there are many national and international experts, but also by the fact that we have a very strong 60-ish strong individuals with experts in obesity that are globally representative, multidisciplinary, including academicians and clinicians with specialization in obesity care, scientists that have track records of work to understand clinical manifestations of obesity. We have public health specialists involved, patients representatives, and also WHO representatives. So it's a really globally representative expert group, and I hope we will be able to come up with recommendations and definitions that are globally relevant by design and intent. So what is clinical obesity? We are framing clinical obesity and in the process of defining more granular criteria for this as a condition in which the risk to health associated with excess adiposity has already materialized. So we're not talking about a risk for the future, but a risk that has materialized and can be objectively documented, clinical obesity, by specific signs and symptoms that reflect biological alterations of other tissues and organs consistent with extant illness, and also with the state of systemic chronic illness. So that's the goal, the general framework. And to do that is not easy, because what I call the knee-jerk reaction is when you have to say and name what are the clinical manifestations of obesity. Very often, even obesity experts will say, well, diabetes, well, cancer, because it's associated with obesity. Those things don't apply, because if you need another disease to define obesity, then obesity is not a disease. So we need to define what are the specific impact, what is the specific impact and dysfunctions that are due to obesity, and that make organs or the individual as a whole not normally functioning, regardless or independent of the presence of other diseases, etc. So this is very different. In fact, this exercise we're running is very different than other exercise that in the past looked at obesity scoring system and staging system, because what these systems have done is staging this risk associated with obesity. And in fact, in doing so, they look at whether or not the systems look at whether or not there is diabetes, hypertension, or other diseases. And they say if there are, you have a score stage of certain. This scoring system are extraordinarily useful in the clinic to define individual specific risk, level of risk. But again, they don't help us define clinical obesity, because they don't point to how obesity alone, without all those other things, could cause ill health. So also, one of the things that makes our job difficult is that, of course, we are used to use BMI and in absence of it, other forms of anthropometric measures of obesity. And what we would like to do is to say, oh, well, let's identify another marker, maybe not BMI, that is more suitable to define illness. And the problem is that this cannot be done because all this BMI, waist circumference, and other anthropometric measures of obesity have been studied so far, consistent with the definition of risk obesity as a risk factor, to study how, if and how they predict risk of future morbidity and mortality. But they have not been studied in terms of, not at least not enough, in terms of whether or not and how they reflect ongoing dysfunctions in organs in the kidneys or the heart, et cetera, et cetera. So we don't have a biomarker, we don't have an anthropometric measure that is suitable to do just that. So we don't have an easy diagnosis of this. We have to be pragmatic and do it at a clinical, with clinical evidence and manifestations. Just to give you an example, some people say, well, we do for diabetes, we just use one single biomarker, the glycemia, to define disease. Why we shouldn't do the same for obesity? Well, ideally, we would like to do the same for obesity. It's just not possible. The reason being that diabetes, unlike obesity, has been known as a disease for thousands of years. And in fact, it was conceived as a disease, not because of a biomarker, but because of the clinical signs and symptoms associated to diabetes. People with diabetes, even before it was known to be associated with hyperglycemia, showed signs and symptoms such as polyuria, polydipsia. They had, they were thirsty. They were making a lot of urine. They had fatigue. They lost weight because of waste due to the alteration of energy homeostasis in diabetes, and so on and so forth. And they would die. They would go on and die from diabetes back then. So it was clearly understood as a clinical illness before it was diagnosed as a dysfunction of one or more organ. And then by glycosuria or blood sugar levels were found to be reflective and predictors of those organ dysfunctions. But we don't have the same thing for obesity, so we can't do that yet. The key difference also that we need to keep in mind to define disease in obesity is that a diagnosis of an illness is focused on an individual. It's patient and not population. And also it's focused on a precise point in time, here and now. Anything that we've done on obesity is always looked at population level and future, so it doesn't apply. Also, disease must have a pathophysiology, a pathogenesis. The pathogenesis is a process that includes a cause, what we call the etiology, and the consequence of that cause on cells, tissues, organs, eventually causing alteration of function that in fact is associated. It's that alteration of function that causes signs and symptoms of illness or alteration of daily activity. So in other words, the illness of an individual. As long as your organs are functioning, the question is whether or not you have a disease might still be a question, but certainly you don't have an illness. And so we haven't defined illness yet because we haven't defined what the typical alterations of organ functions are that are secondary and directly associated with obesity, not to other obesity-related associated diseases. And of course, then the process progresses in time to cause end organ damage, which we call complications, etc. So clinical obesity is when these clinical manifestations are apparent and detectable. So the Lancet Commission is it's a sort of consensus conference, but it's more than a consensus conference. It requires a lot of work because there's a lot of opinions, as you can imagine, of these things. And Rachel probably can witness that discussions are sometimes not so easy because there are opinions that looks very polarized and different and diametrically opposed on many fundamental issues. But I have to say that over the 9 months almost so far that we have been at work, we have eventually found a common ground just as soon as we move away from the more philosophical or generic principles and look at the evidence, scientific evidence. Because as healthcare professionals, what we're good at is to really agree on clinical evidence. Maybe when we leave it at opinions, that's more difficult. So finally, I want to say that reframing obesity and defining obesity clinically, which is exactly what we're trying to do, is we're defining obesity clinically, meaning we're trying to reframe the whole of obesity, of course, as a as it implies, means that we could identify appropriate targets for prevention and treatment strategies. We would not suggest that you have a clinical illness and you should, you should be content at implementing preventative measures. For that individual, there would be no benefit. So it's important to understand this difference. Patient-centered treatment goals can be developed. So, for instance, risk mitigation could be important. It could be a treatment goal for some patients with preclinical obesity, perhaps, whereas improvement or remission of clinical manifestation of organ dysfunction is the fundamental goal of treatment in people who already have an illness, and clinical obesity, for instance, would be an illness. And would provide a crucial conceptual and scientific argument to address having this clinical definition of obesity will finally allow us to unlock that kind of deadlock we have reached in this debate about obesity as a disease. I also believe it would reduce societal stigma, because it is clear that illnesses cannot be fixed spontaneously, nor by some, an individual decision to do so. So having a sense that obesity itself, not through diabetes or other diseases, but obesity itself can lead to illness, will also go a long way in addressing bias and stigma in societies associated with obesity. And finally, I want to conclude by saying that we are definitely conscious that we are dealing with a very difficult subject. So it's a daunting, it was a daunting, and still is a daunting task for many, many reasons. But we also know that, daunting as it is, whatever, this is a very controversial issue, and whatever conclusion we make, we will be criticized from left, from right, from up and down. We anticipate that. The fundamental and easy criticism to any initiative around obesity is always, especially one that tries to define it as an illness, is that we are going to try to medicalize obesity. Medicalize has been used with a negative sense, like a way to, endorse utilization of expensive tools and interventions, etc. So typically say medicalizing obesity is bad. I would turn it around to say that medicalizing obesity is not bad. It's actually the right thing to do, and is the healthy thing to do, and the thing that we have never done, because it's exactly because medical problem like obesity, arguably the biggest medical problem mankind has ever faced, because this medical problem has never been medicalized. Medicalized meaning portrayed, framed as an illness, as a clinical entity, is exactly the lack of that, the medicalization of obesity that has allowed to stigmatize about people who have the problem, discriminate against them, allocate resources in a completely rational fashion between prevention and treatment. Where you need treatment, you use prevention, and so on and so forth, and substantially made us completely unable to fulfill what I say at the beginning. Are the goals that Hippocrates said should be set for any healthcare professional. So medicalizing obesity is the right thing to do, indeed. Thank you.
Thank you very much, Francesco, for that really thorough overview of the work that you've been doing with the Commission, and also, of course, your research and in your career as a clinician and a researcher. And I think it's a very, very complicated issue, and you've tried to frame it in a way that makes sense to us. But just to clarify for everyone that you're not talking about changing the definition of obesity. You're not talking about whether that's the right definition, which has been agreed by the World Health Organization, of course, but you're taking that next step about when it becomes a clinical issue, and therefore it needs to be looked after in that way. So I think that's a really important distinction that I hope people have gotten. So I'm going to stop recording now, but people, please do feel free to ask some questions via the chat. Please put your hand up, and we can just take them one at a time for this really important discussion. So I'm going to stop recording now, and feel free to pop your hand up and ask some questions. If I can work out how to stop recording. Here we go. Okay.